Alrighty. Uh, Thanks y'all for being here. And thank you to our speaker, Dr. Gopi Astik. She is an academic hospitalist, quality researcher, and associate professor of medicine at Northwestern University Feinberg School of Medicine. She completed her medical training at the University of Missouri, Kansas City School of Medicine and a master's in healthcare quality and patient safety at Northwestern University. She's an active member of the Society of Hospital Medicine and has given national talks on a variety of subjects, along with serving as the course director for the SHM Converge conference in 2025. Her research interests include diagnostic errors and clinical reasoning feedback for clinicians, hospital operations and service model design, and the impact of innovative technologies on efficiency and patient outcomes. She serves as the Director for Professional Development for the Division of Hospital Medicine and is the lead medical director of clinical documentation at Northwestern and has spoken nationally about methodology and tactics used by the clinical documentation department to optimize risk adjustment and other quality metrics. Thank you for being here, today, Dr. Astik.
Thank you so much for having me. I have a lot of friends just like Dr. Massert and many others at Emory, and always happy to be here. It's a warm day in Chicago, so I feel like my sunny disposition will hopefully help this topic of diagnostic errors and clinical reasoning feedback in hospital medicine, which is a topic that's really near and dear to my heart. And kind of have some, see if this moves actually. Oh no. Here we go. Okay. We'll discuss kind of the background of diagnostic errors in medicine, summarize some findings and some takeaways from our study that we did here at Northwestern that both looked at kind of the number of diagnostic errors along with clinical reasoning feedback to clinicians. Discuss a few strategies to kind of mitigate errors and then future plans for this research. Hoping there's time at the end for kind of questions or discussion as well. So no real disclosures. I have some research funding through the Moore Foundation that really funded mostly my master's, the doctor's company that helped with part of this project, and an AHRQ for some other work as well, but thought I'd call those out. So the story really starts back in 2019. I'll also say most of the pictures that are in here are ones that I've taken, so of the Chicago especially. And back in 2019, as hospitalist, I was also at that point like medical director of one of the units. And I was on service, rounding like normal, finishing a week on service. And I had a patient who I signed over to a colleague of mine, a guy with 80 years old, kind of multiple comorbidities, came in with influenza A, was in the ICU for a few days, and then was kind of, slowly getting better on the hospital medicine floor after leaving the ICU. Kind of had a little bit of the dwindles, just a little weak, kind of couldn't get much out of bed. And so we're trying to kind of slowly get him better. Also had multiple comorbidities, including things like a brain aneurysm that we were concerned about, anticoagulation, had a history of some dysphagia. So we're working on a couple different things. I signed him over to a colleague of mine we do, Monday to Sunday. So on Sunday evening saying, from the flu, slowly getting better, plan is rehab before home. And I took Monday off, as I usually do. I call it my scheduled sick day after I finish service. And then came back in on Tuesday. Since I was the unit medical director, I have to run interdisciplinary rounds on the unit. So I came back in to run the list with my colleague, and he mentioned the patient was on a heparin drip. I said, no. We had this whole discussion with neurosurgery when I was on because his brain aneurysm, they thought the risk outweighed the benefits. There was no need for it. And my colleague said, oh, he has a PE now. So that's really why the heparin drip. And I kind of chewed on that for a while, and I said, okay, it's fine. And then I went back in and reviewed the chart and found that not only did he have a PE, he had a pretty large PE with some strain. And in looking back through the record, the patient had gotten a little bit more hypoxic. Like, he was maybe on 1 to 2 liters when he left the ICU, had gone up to like 3 and 4 sometimes. And had also been a little bit more tachycardic, maybe in like the 110s, kind of from like 90s before, and nothing that seemed super alarming, but enough that I hadn't recognized it. I never documented it. I never realized it. So I definitely missed this guy's PE. It wasn't like this happened on that Monday that the PE came up. It was obviously something that had probably been there for a couple days. And what really threw me about this story was like, number one, yes, of course, the miss. I'm not crazy enough to think that I don't make any mistakes, but I had no idea that this had happened, and that my colleague that actually took over for me is actually a really good friend of mine and didn't feel the need to kind of tell me. And so it really made me wonder, like, how often is this happening? And I found that when I was handing over service every week, it kind of shattered my thoughts that I was doing a great job. And I felt like the need to kind of keep checking charts and seeing what was happening every day. And I wondered how often this was happening with my colleagues. So I started talking about it, and people said, we think about this a lot. Like Monday after service is really tricky for us. And we are often looking at the charts the next day to figure out what happened. So it really kind of got me thinking that how often are really errors happening? And, how can we find out about this and what can we do about this? So I've not really looked into diagnostic errors before. I knew they kind of occurred, but really looking at the definition and per the National Academy of Science, Engineering, and Medicine was a failure to establish an accurate and timely explanation of the patient's health problems and or communicate that explanation to the patient. The focus of my work and my study is really part A of this. I think part B is great, and I would love to delve in that more, but I think I've been mostly focused on the accurate and timely explanation and really figuring out how often errors are occurring. And there's different types of errors. There's a delayed diagnosis, really where a diagnosis should have been made earlier. A wrong diagnosis is, a diagnosis that was found to be incorrect because a true cause was discovered later. And a misdiagnosis where really the medical complaints are never really explained during the encounter. And these are not mutually exclusive. You can kind of have one or both at the same time. And especially I'll go back to the delayed diagnosis. That's really context dependent. So when you think about it, how long does it take to get testing done at your site? I will say MRIs can take a bit here at Northwestern. And if the MRI doesn't happen until hospital day 3, is that a delay or an error because it just took that long to get the test done? Or was considering the diagnosis kind of earlier important? So I think it's also looking at an error here might be a very different error at Emory, and it might, I think all of our contexts for our healthcare system are very different. So I think it needs to be a study that's done by locally to actually see what context matters. And diagnostic errors are pretty common. I felt a little bit better knowing how often they occur, but not really great for our patients. So depending on the literature, there's 40,000 to 4 million cases nationwide. If you look on the bottom of the slide, I have some QR codes that are kind of gray. I have bigger QR codes later, but in case anybody wants any references, feel free to reach out. Half of diagnostic errors are related to cardiovascular disease, infections, and cancer. And that's kind of David Newman-Toker's great work that he's done, kind of looking at the big three. 0.3% of all patients suffer from preventable and serious harm, including disability or death due to diagnostic errors. And there's some other studies later that we'll talk about looking at some of that. And then that they really account for the largest fraction of malpractice claims and severe harm and highest total penalty payouts. So I think this happens a lot, and we don't really know how often they're happening. And I think the ones that we hear about are the really bad ones, but I think there are smaller errors. Like, I don't know if mine would have been reported anywhere. The patient had to change medication, but he didn't, escalate care. Nothing really happened. Maybe he was here for management of that, but I don't know if how much of him being on a blood thinner and treating this PE changed his length of stay in general. So I don't know if there was any way that I would have received feedback on this case. So looking into some of the literature, there's been some studies that were kind of looking at autopsy studies of ICU kind of patients as a systematic review that was done, that was in BMJ quality and safety. And 28% of autopsies had at least one diagnostic error. And vascular events and infections were the kind of leading causes of lethal misdiagnosis. This was a study that we did during the COVID pandemic. I think if anyone remembers that time, I feel like everything that came in was COVID. So we looked at how often were there diagnostic errors in patients that were really PUIs or under investigation for COVID. Were we thinking that everything, acted and smelled like COVID? And we found that there was 14% diagnostic errors in the process faults. I think Emory was part of this too. Clinical assessment, testing choices, history taking, and physical exam were the biggest process faults that were seen in that study. We also looked, so this was the bigger kind of upside study that looked at diagnostic errors in hospitalized adults who either died or were transferred to the ICU. So really, a subset of patients that were sick. This was a large multi-center study. We were happy to be a site, and I believe Emory was as well. And the process faults really were problems with assessment, test selection, or interpretation and physical exam. This was published in JAMA, and in the study, 23% of ICU transfers and inpatient deaths had a diagnostic error. Out of 2,491 patients, 13% had a diagnostic error that produced permanent or temporary harm. 7% had errors that led to death. And of the 564 patients with an error, 23% of those errors led to death. So 128 patients, which is, a lot to think about. I think in looking at a lot of the studies that have been done so far, a lot of this work kind of started in the 2000s. Hardeep Singh had done a lot of work kind of on the outpatient side. There's been some great work by Andy Auerbach and multiple other people looking on the inpatient side, but most of this work is really retrospective and kind of descriptive of errors, but doesn't really have any interventions. And most of these are triggers, right? Whether it's ICU transfers, readmissions, deaths, like the ultimate outcome. There's not, these are patients that are like a subset that's chosen, but I really wondered selfishly, because it's kind of all about me, how often was this happening for someone like my case that I handed over to a colleague, nothing really changed. Eventually they did go to rehab and kind of went just as normal. Like, how often are errors happening there? And knowing that there might not be as much harm or as much large impact on patients, but I still think it's a great learning opportunity. So selfishly, I wanted to know how often was this happening in my patients, and especially patients that we regularly pass on, but also for my colleagues and I to know that if there was a way to kind of formalize some feedback to find out how we did doctoring. I feel like all the feedback I get from the hospital is like the food was bad and the ER wait time was really long, which I have no control over. But like how I do actually diagnosing here, I think it's what people want to know about. Um, so how could we do that? And has there been any work and kind of feedback? And around the same time, Kathleen Lane from the University of Minnesota and Andrew Olson and colleagues had published this paper kind of looking at resident feedback for diagnostic reasoning after their handover. So this was peer feedback by residents. They really used their like EHR secure messaging to give feedback about really were diagnoses changed from shift to shift, and then were the diagnoses considered major. They didn't say if it was an error or not, but really provided information about a diagnosis change and was it a large change or a small change, just to get some information to each other from mostly their night float residents. So when thinking about a possible study, I was interested in like feedback related to clinical care, so like diagnostics, and then feedback from somebody involved. So ideally, the person that took over my patient, could they give me some feedback? And kind of brought this to my group and said, this is what I'm thinking about doing, sending a survey, having you guys involved. What do you guys want to know about? Because I needed a carrot, because I know that although I felt very passionately about this, I don't know if my colleagues did. And they really wanted to be able to give and receive feedback about like notes, handoff, and communication, because I think those are things that can kind of either make your day or break your day, depending on if you take over on a Monday and have to rewrite all the notes, or if the handoff isn't great and you kind of come in blind, or if patients and families didn't feel like adequately informed, it kind of can derail your day. So they wanted to both give and receive feedback on these things because that was important to them. So we're like, okay, we can put all this together. Looking at feedback, it's been shown to improve diagnostic performance, but clinicians don't really receive much feedback on diagnoses because I think it's hard to really implement, and even less on clinical reasoning. If I can say your diagnosis was wrong, but it's like, but where did I deviate? Like, where was my schema? Was it my problem representation? Like, where did things go wrong? And some possible reasons for the little feedback that we receive is, number one, I'll say the silos in our system is that, as a hospitalist, for me, I am localized to not only a floor and a unit, I'm localized to specific beds. So I do not leave my little area because all of my patients are in one hallway, which is great because I don't have to go a lot of places, but it also means I don't interact with a ton of other people. And I'm kind of also always working with the same one person who's also on the floor with me. So we're kind of in these silos. GI comes in rounds and kind of leaves, but they're not on the floor with me. There's nowhere for me to really interact with them regularly. So trying to find a way to actually break out of those silos and discuss with people together. Patients usually transfer and transition. I'll say with being so localized as we are, it's great for teamwork and great for efficiency. But our patients, like if they need, a heparin or not, a DILT drip, they're going to go to a different floor. If they're going to need, specialized oxygen therapy, they're going to go to a different floor. So they're constantly transitioning and transferring between. And each of those locations almost seems like its own encounter. Like what happens on one floor, then it kind of goes to a different floor and it doesn't restart. You kind of pick up, but it's almost like its own finite little encounter there. The diagnostic process really isn't linear. There's multiple ways to get to a diagnosis. And if I say that a patient had shortness of breath and a cough, the difference between pneumonia and heart failure could be a little, it could be a little bit of both. It could be one very blatantly more than the other. And it really differs on kind of what do you do first? If they're short of breath, do you give them the Lasix first? Then do you also give antibiotics? Or how do you kind of decide which one goes first? And that really gets to the last concept of like really situativity that's been described as like the clinicians that are there, people that are in that context and how your environment really describes your decision making of like almost like you weren't there. You can't really say like retrospectively, we can all say, when I look at a note and I say one day the diagnosis wasn't there and the next day the diagnosis was there, it seems like it was just forgotten before but you don't have like the context of what actually made that diagnosis occur. And so kind of figuring out how to get the people involved in the care, involved in providing the feedback. So we really wanted to see how many diagnostic changes do we see from care transitions from one hospital to another? How many of these changes are really errors? And are there trends in the type of errors or causes that we could try to work on to kind of mitigate errors? And then really giving peer feedback from the involved clinicians. We didn't want to like Monday morning quarterback this and say like, looking at this case, here's exactly what you should have done. But we wanted this to be driven by the people that were actually seeing the patient rather than it just being purely by case review. So this was a paper we were happy was published in the Annals of Internal Medicine this past year of utilizing care transitions for diagnostic error detection in hospital medicine patients. So I'll say for this part of the study, we mostly just focus on the diagnostic error part, and then the feedback part will be a follow-up manuscript because they were really interested in the kind of the error part of this. So the design of this was really hospital medicine service. At that point, we had about 70 physicians. Now it was like 120. I can't keep track of how many people are in my group, but there's a lot. So at that point, we were at 70. We were 7 on, 7 off, and we used a verbal handoff. We have now since gotten with the times and switched to an electronic handoff of sorts with maybe a little bit of a verbal discussion. But at this point, we were old ages, verbal handoff. Inpatient non-teaching general medicine services were involved, and we really focused on patients that were hospital day 2 through 5. And the reason for that were we wanted it to be at least hospital day 2 because then the rounder that signs this patient over had a day to really think about the patient, round out them, rather than it being a morning pickup that they just sign over that evening. And then not more than hospital day 5, because by then the plans are kind of set. We kind of know what's happening. We're waiting for something. But more of the diagnostic process seemed to occur in looking at our data in terms of testing that was being ordered in consults from hospital day 2 through 5. We excluded our observation line mostly because our length of stay for those service lines isn't as long. The oncology line, because they're just a little bit more specific, had some more planned admissions. And then the teaching services in this phase of the study. So we created a questionnaire in REDCap that really asked about whether there was a change in diagnosis. So if it would say, I'll show you, kind of says, to what extent did you change the main clinical diagnosis for this patient? That's not documentation related. You guys heard my bio. Part of my job is clinical documentation. This is not about queries and saying that the fever was due to sepsis, but really, did you change diagnosis that the patient had? And if you said not at all, then it didn't really, it kind of moved on to the next question about handoff and communication. But if you said to some extent or to a great extent, it asked you to say what was the initial diagnosis, what was the post, and then do you think this was due to diagnosis change, disease evolution, or diagnostic refinement? And this really comes directly from the Loop study that they had done at the University of Minnesota and multiple other sites. Really, they use this exact phrasing, so we put it in there. We also asked about if there was any change to, medications, any consults, procedures, disposition, and then of course the documentation handoff and then feedback, and an open feedback spot for people to put in whatever comments they had to give to their colleagues. I love a good process map. I presented this before, and I think my process map was a little unruly, so I remade this to make it look a little bit nicer, but I'm going to just bear with me. So a hospital's on service, so I'm going to use Dr. Massert as an example. So I signed over patients to Dr. Massert. So she would receive a survey maybe Tuesday of her service week, so hospital or her service day 2, to ask about two specific patients if they meet study criteria, up to two, I guess. And if any of them had a diagnostic change or not. And if she says no, then they just ask the other questions about feedback. And then that information is added on to the feedback form for me because I gave my patients to her. If she says there was a diagnostic change, then that case is uploaded by our research assistant into a separate form where our study team would, two of them would independently review the case on their own and decide whether there was an error or not and really adjudicate whether about harm. They use a standardized tool, which I will show. If there was a harm, then that information is not only provided to the individual, but then all the de-identified information about the case is used just to provide the cause of the error, the diagnosis for our leaders. So we kind of we compiled those over months and we would just provide like, here are some of the errors that occurred, but completely de-identified. None of this was used for any, evaluation purposes for faculty. And that was a IRB stipulation, but also we didn't want this to be something that people were evaluated by. This is purely for learning. And then also, even if there was no error or harm, we still provided that information back to the hospitalist to say the diagnosis changed, but this seemed to be more disease evolution. So this was, just so you know and you're aware. So the hospice really wanted as much information as they could get, and that's kind of how we did this to make it a little bit easier for those of you that don't love process maps. So we identified patients transferred from one hospice to another weekly. We surveyed the hospitals that assumed care about diagnostic changes, med changes, all that stuff. We evaluated how many of the diagnostic changes were errors, and then we compiled the feedback to provide to the hospitalist directly, and then trends for leadership. So our chart reviewers were great. One of actually the colleague that took over for me in that case that found the PE ended up being one of my co-investigators because after I said, like, why didn't you tell me about this? He was like, oh, it never crossed my mind, but we should look into this. How did this happen? So I was very thankful he joined our team. So all reviewers were trained in pairs, and they used 30 curated cases that we kind of, scrubbed from the EMR and really had information that we just put into kind of cases. So they would review 10 cases independently and then meet. And they did this 3 times to kind of adjudicate, discuss, and ideally kind of get on the same page. And they were instructed that if findings were equivocal, if they were really on the fence, we actually said not to call it an error because we weren't trying to overcall errors here. And if it seemed like it was on the fence and really not sure, then we would rather err on the side of not calling it an error. But also these are the kind of cases they could meet and discuss and kind of see where each other stood too. If the 2 reviewers did not agree on whether an error was present, then a third reviewer was a tiebreaker and was assigned. The study teams were recused themselves from any cases in which they were involved, whether they were the initial person, the second person, they were not involved, or even took care of the patient later in the stay, they recused themselves. And then division leaders, really except for me, were not included in any chart reviews or provided any individual data. So we use the revised Safer DX from Hardeep Singh that was created mostly to look through a case and decide whether there was a diagnostic error, kind of putting some, kind of the questions that it goes through is like, was the document history suggestive of an alternate? Were there red flags that weren't acted upon? Was a differential not documented? And then kind of at the end it asks, in conclusion, based on all of the above questions in the episode of care, was there a missed opportunity to make a correct or timely diagnosis? So rather than have it with a score, we kind of did it as a Likert. So had people choose like between strongly disagree to agree, and then had them describe the error. And this was a chart reviewers that were really putting a synopsis of the case. And this is exactly what we use for feedback. Their synopsis, their review of what they saw, and then any kind of pearls or thoughts they would give back to the clinician that way. But also, if it wasn't an error, really describing kind of what happened, and so we could easily copy and paste this into a review. So getting to some kind of results. So 1,011 patients were randomly selected for inclusion. We had 827 patients without any diagnostic changes, 184 patients with diagnostic changes. I was very thankful for the survey response rate was not 9%, it was 96%. I'm sorry. But I was very excited for the response rate. We had 5 cases that needed tertiary review because there was disagreement about the presence of an error. And then 3 cases where the initial reviewer recused themselves due to being involved. So those cases were reassigned. 125 patients did not have diagnostic errors and 59 did. And once we had the number, like the patients that had errors, we actually met together, discussed every case, and kind of put them in our own buckets of what was the error and where, like where was there something that broke down. And we didn't say that each person, like each case only had to fall into one bucket. But we had 34 cases where there was a missed component in the EHR, which was very surprising. 12 cases with a failure to order a test or a consult, 12 cases with a failure to consider a diagnosis, and 10 cases with missed physical exam findings. We started these in 2019. We paused for a bit during COVID just because I think the whole world was on fire. And then we restarted again. And from our reviews, actually, our inter-rater kind of reliability of our reviewers was pretty good at with a kappa of 0.68. Our diagnostic error rate was 5.8%. Looking at the types of cases, they broke down into cardiovascular infectious were the top two, and then followed pretty closely by neurology and then by GI. So we had a good mix of cases of what the diagnoses were. The most common diagnoses with errors were drumroll, heart failure, pneumonia, and VTE. So not completely different from what has been described before, but it was interesting for us to see that. So causes of errors, we kind of went through some of these, and I'll go through each of them separately. So failure to consider a diagnosis, the primary kind of condition for those were cardiac, and then followed by neurology, infectious. And I kind of just chose random cases from these. So an 82-year-old male with a history of chronic AFib on warfarin, HFpEF, aortic root dilation, hypertension, presented with UTI and AKI, had dyspnea on exertion, weakness, and lower extremity edema on admission. The first hospitalist provided antibiotics and stated that lower extremity edema was likely due to malnutrition, but dietary didn't really document malnutrition. The new hospitalist came on service and noted the patient did have 3+ bilateral extremity edema, elevated JVD, and persistent dyspnea on exertion. So they were treated with IV diuretics and had improvement of their edema and symptoms. So there was a delay in the diagnosis of the acuity of the HFpEF. Failure to order, the primary was labs, and then kind of consult and imaging were equal. So this is a 73-year-old male with a history of sleep apnea, HFrEF, CKD, obesity, type 3, admitted with chest pain, dyspnea, presyncope. Patient, it's a female, reported her substernal chest pain came on suddenly 6 days prior to admission and was dull, but a constant pain, which was intermittently pleuritic. Troponin was normal, heart rate was 105, hypertensive to 180/80, and EKG with sinus tachycardia, but otherwise without acute changes. So the first hospital ordered a nuclear stress test, which couldn't be done over the weekend. And the second hospital came on service and ordered a D-dimer, which was positive, and the CT actually showed large bilateral PEs. And since her chest pain had been present for 6 days, had been pleuritic component, and the D-dimer should have been checked earlier. So we thought this was a diagnostic delay and error. And thankfully, they couldn't do stress tests over the weekend because this patient had pretty big PEs. A missed exam finding. This was really interesting to us. That volume status was a commonly missed exam finding. And I'm hoping that in the era of POCUS that this will be something that we can also mitigate or improve at least. So a 41-year-old female with recent COVID diabetes, PE, admitted with sepsis. Patient reported weakness and leg swelling, fevers, and chills at home, had a white count of 14, lactic acid of 4, AKI procal 2.2, tachycardic, mildly hypotensive, which was responsive to fluids. Patient was placed on broad spectrum antibiotics, which were de-escalated after 24 hours because they had a CT, chest, abdomen, pelvis, chest x-ray, and UA that were all negative for any infection. The new hospitalist came on service and noted that the patient had right lower extremity erythema, excoriations, and a purulent drainage. And patients said this had been present since admission, and it was also noted in a nursing flow sheet and in the ER. So the patient was diagnosed and treated for purulent cellulitis with improvement in symptoms, and there was a delay in the diagnosis in notes. And then this was our largest finding was missed EMR components. And the primary was history, followed by like imaging, then vitals, labs. And so a 35-year-old male with a history of sleep apnea, obesity, hypertension presented with dyspnea, cough, fever, found to have COVID without hypoxemia. The patient was admitted with improvement for 3 days prior to handoff. And the second hospitalist noted persistent hyperglycemia between 200 and 300 on chem panels. With no steroids or history of diabetes, the patient, again, was not hypoxic. The A1C was ordered and returned at 9. The patient was diagnosed with new diabetes and started on therapy. And the hyperglycemia was not noted by the first hospitalist. No kind of point of care testing was done, no insulin or labs ordered. So there's a delay in the diagnosis of diabetes. And I chose this case to say it's not just the primary diagnosis we were looking at. We really asked about if there were any diagnoses that really changed in the patient. So although this patient was mostly came in with the COVID, but this was a secondary diagnosis that was likely missed. I think the question when you think about these is really what was the harm? And these patients are really what was the impact. And I think to say that most of these patients there wasn't any harm. So the blue was error with no harm. The orange is error with some harm, and the gray is error with death. And that's really one case. So for most of these patients, there is no harm. And it doesn't, I don't know if it would come across for even our quality people or risk people, or so that this would come across as a case to review. So for these, I think the common thing is that it's a great learning opportunity. It didn't have a super big impact on patients, but these are errors that are occurring. And I think this is an opportunity to look for these, and especially service lines where patients remain on the same service line. And then the feedback part of this kind of, again, this is a separate part and it will be a separate paper. The main thing we really focus on, I think if I could make this psychological safety as 1, 2, and 3, that was our main kind of priorities for this, was really wanted this to be something that was safe, that people wanted to know about, but also people were looking forward to. We didn't want this to be something that seemed punitive. We don't want people to feel bad about it. We also wanted people to have time to process. I think everyone takes in information differently. So, of course, some people might want it emailed, some people might want to meet. So we thought we'd kind of do a little bit of both, where we actually emailed a form, which I'll show you, to the clinicians involved. And we did it on a kind of, quarterly basis, so people knew their form was kind of coming. We would say at that same time, send out a little Google form to say to pick a time to meet with one of us from the study team to actually discuss their feedback, and then also give us time to ask them how it went or what they would want to change about the process. So we did both, read it yourself, look at the case, kind of look it up yourself. And then some people came in with questions themselves, had debriefed and wanted to talk about the feedback. Some people just kind of came in blind, and we all have colleagues that are both ways. But it really led to some robust discussion. People really enjoyed these kind of meetings, and they weren't, it wasn't taxing. We would say usually pick a day that you're on service that we can step away and go grab a cup of coffee and talk about this for like 5-10 minutes. Like it wasn't like a long meeting, so it wasn't taking too much of their time. So these were the feedback forms. So it was really, based on how many surveys they'd received, how many patients were reviewed, and really depended on how often the person was on service, on how many patients, obviously we would see, because it's depending on their weeks. And since we didn't include the teaching service, some people didn't have as many patients because they might only have 1 or 2 hospitalist weeks in between blocks on teaching. And so, for this one, this patient had a mass that was changed to a diagnosis of sarcoma for pathology results. So not an error, really, that was diagnostic refinement. And the second one was a patient with heart failure that came in with chest pain, abdominal pain, AKI, was treated with Lasix without improvement and had some new hypotension. The subsequent attending came on and recognized that the patient had some hypoperfusion and it was really more cold and wet than warm and wet. Stopped the Lasix, and the patient actually went to the CCU for dobutamine support. So, and in this case, I'll say this person didn't know that the patient went to the ICU and that this had happened. So they were happy to kind of look at that and be able to kind of look at that case again as well. And this is the feedback that the hospitals really wanted, right? This is the one they requested. They were very happy with the diagnostic feedback later, but this is what my carrot to get them to do it in the first place was. Patients and families were informed of the plan, and the average was the gray, and the purple for Northwestern purple was their score. Handoff contained all the information that was needed, and then the quality of documentation. And then there were open kind of areas for feedback. And I will say over 95% of the feedback that people got was very positive. I'll say as hospitals, we're generally like positive beings and like to give, we're academic, we'd like to give positive feedback. So there was a lot of, you did a great job. Thanks for calling GI. The family loved you. But there were also some constructive nuggets of like maybe, maybe you could remove the todays or the yesterdays from your note because it's inaccurate. And they also could say, maybe your notes kind of seem to have a lot of unnecessary information. Could you remove that? So provide some good information, some nuggets, and also some clinical reasoning thoughts. So after we did this with the hospitals, it was actually pretty well received. And the first question we were getting, especially from a lot of our academic folks, is like, how can we do this with our residents? Like the residency came to us asking for this. We actually did the same kind of project with the ED, and we're kind of looking through that those results now. But started designing a project that's now in place with the residents. We have some very early description about this, is how to do this kind of with residents to provide some feedback. So going back to our IM residency, our night float teams are the residents come in at 7 p.m. They kind of do admissions overnight. They usually kind of start their treatments, do their documentation, and then go home at 7 a.m. But there's no interaction with an attending at that time. They kind of do a little bit of a handoff around 7 a.m. with the residents, so resident to resident handoff, but there's no opportunity for feedback. And when we were talking to the rounding teams, were like, we identify changes, we change diagnoses, and there isn't a process to provide that feedback back, but also really it isn't top of mind because they're just kind of going about their business of seeing patients. And similarly, the night float residents, they wake up. Some people, they fall into two buckets. Some of them don't really think about the patient. They get ready for their next shift and kind of go in. But a larger proportion of patients were actually the bottom component where they were up looking at their haiku on their phone or looking up Epic at home because they were nervous about what changed or how the patient did. And they felt like they felt like night float was difficult because they felt alone a lot of the night, and they were making decisions that they didn't get any information about how they did. And the only cases they really heard about directly were ones that went really bad. So at 6 p.m. they'd come back in, and it's kind of after maybe getting some rest or maybe not, depending on how anxious they were. So they requested kind of, they wanted to see if we could find a way to provide night float residents some feedback from the day team as they pick them up, if we could operationalize a way to kind of provide that feedback. And similarly, I think as we're kind of not criticizing, but as we're reviewing or evaluating their admissions, we also wanted to know the experience of night float residents and really what impacts their learning. It kind of seems to be this time where no one else is really there and they're kind of there overnight. It's very stressful, but we didn't have exact information of what makes it stressful and what's taking their time. How are they doing this? So the objectives of the study was to describe how often diagnostic changes occur on transition from night float resident to day team, how many of these changes are errors, provide feedback to the internal medicine residents regarding diagnostic changes and errors, and then separately obtain reflection and feedback from the IM residents on night float about their experience and education to provide to the residency program to figure out how we can improve their experience on night float. So the process is the night float, I don't know why this keeps changing. The night float resident admits patients overnight. So let's say day 0, the teaching attending receives surveys kind of like the next day about patients that they picked up to ask whether there are any diagnostic changes. The residents complete their anonymous survey about their feedback about the night float experience kind of while they're on night float ideally, or kind of near the end of their night float block. We try to get them the feedback from the attending every 2 weeks. So we kind of trying to get in there and get the feedback from the attending and have it sent directly. And then separately, any cases where there is a diagnostic change from the night float to the day team, we send for review to the study team. We would love to make that a little bit faster. We just haven't figured out how to do that. And then again, provide the feedback about any diagnostic changes and errors back to the resident directly, and then provide trends only to leadership. So this is very, very, very preliminary data. Oh my gosh. We had 208 surveys sent. We've had 127 patients that have been reviewed, so about 61%, I believe. It might be a little bit less depending on the number per survey. About 25 diagnostic changes, 15 errors, and 3 with harm. We're still compiling the information about the resident experience, so I don't have anything to show on about that. But I feel like looking at this, we're still seeing diagnostic changes and a lot of changes, some errors, and then less harm. So we'll try to compare as we go across, and hopefully I can come back and tell you about that information. And really, what have we learned from our errors? Really, the main kind of takeaway from this is trends and vitals and labs are easily missed. When we're looking through, especially looking at the data in the EHR, it's hard for people to kind of parse through what's changed, what's new, and there's a lot of different ways to look at it. There's a lot of chart review time, but also with the time constraints, people feel like I'm kind of missing some of this stuff. Volume, status, and perfusion are easily missed, especially in heart failure patients. And then clinicians really aren't comfortable with uncertainty. And I think that's important to kind of recognize that we want them to kind of say, what are you not sure about? But people feel really uncomfortable calling that out, even if they're not comfortable documenting it, but how can we talk about this? How can we normalize this a little bit more? The impact on clinicians has really been from this study, people have really started doing proactive feedback plans. So if I'm going to get a survey in a quarter that's going to tell me about changes that you made, I'd rather just find out directly from you. So how about, Tuesday, Wednesday of this week, I'll give you a call and we can talk about any changes that have been made, or can you just text me if any changes were made? People are definitely more open to feedback. We've since kind of paused some of the study as we do other studies. And people are like, when are you going to bring this back? When can we have this back again? And people feel less anxious. They don't feel the need to be checking their computer, looking up on patients as often themselves, because they know they're going to receive either feedback from their colleague, or whenever it's formalized, getting it from a structured feedback mechanism. Really, the question is, what can we do now? What can we do about this for clinicians now to improve care? So the kind of EHR optimization, right? Can you have your lab since admission, like a form that's created? Can you create timelines or graphs, whatever's easier for you to be able to review, and really personalizing your EHR? Along with some AI chart reviews, we've been looking at different AI methodologies or AI tools through our Innovations Institute. And I think helping data mine and helping figure out what has happened, what has changed. There's some really interesting information out there about using chat.
Hello?
Hello? Hello? Oh, can you guys still hear me?
Yes, keep going. Sorry.
Okay, sorry. So using some information, some AI to actually help data mine and figure out what's been going on in the patient's chart, and actually being able to ask specific questions like, what antibiotic is a patient on? What has changed? And I feel like there's a really important tools out there that hopefully will be coming down the pipeline. And we're lucky enough to pilot some of those here too. I'm really interested in Anuj Jalal's work from the Brigham. This is a QR code to their kind of learning lab where they talked about diagnostic timeouts. So for patients that you're kind of unsure about, or even that you're, kind of working up that seem kind of complicated, using this 5-step kind of timeout to really you can actually conduct it with the patient too, to kind of, for transparency of like what your current leading diagnosis is, what you can't really fit into the picture, and what alternatives there could be, but also giving a chance to kind of call out that uncertainty of what else could there be, what else should you be looking at, so that way it's not like when you hand over a patient, you're handing over with a stamped and sealed diagnosis to say, I think it's this, but here's what doesn't fit, see what you think. This is a tool that was created that I was happy to be part of with AHRQ that's called Calibrate DX, to ideally help clinicians review their own cases to improve their diagnostic calibration. So kind of goes through different domains of like, what is your question that you really want to answer, and what is the outcome that you're really looking at? And then the goal is to actually use a tool like this to review a certain number of your own cases and then discuss them with a colleague of what you find. So you fill out this form, work together. My group is actually doing a process where we have people do like 5 cases of their own, review them with this, and then discuss with a colleague as part of our quality, to kind of see, it provides some structured case review, allows them an opportunity to look through your cases, but also allows some like kind of kumbaya debriefing to kind of see how people feel about their performance and if they have any questions about things. So it's been, we piloted it with a few people and they really liked it. So we've kind of spread it out now to more. And for future state, really looking at, where does POCUS fit in? I know you've got some great POCUS people down at Emory, and they are my POCUS go-tos when I have questions. So like, how do we train people more for, especially for the volume exams, but even for other things, to kind of figure out how can we use either POCUS or other technology? How can we leverage AI to do some of this as well, and to help kind of with the workload, the subjective workload and the objective workload of actually looking through the EHR? And then setting changes in diagnosis, like using notes. So that's kind of what we're starting to do, is kind of using some large language models. So rather than having to have the clinician fill out a survey that says that a diagnosis changed, can we actually use an AI tool that would identify when a diagnosis changes in a note, and see if that prompts like more real-time kind of evaluation to see what changed in the case. I have a huge team that I work with. This is not even all of them, but a lot of researchers that work with my team. I think David Gazy's from Emory originally, so probably shout out David. Along with others, my research team, and then my mentors as well. And I'm happy to take some questions.
Thank you, Dr. Astik. That was fantastic. I always learn so much when I hear you speak on this topic. Um, I would love questions in chat, and I know we already had some comments, including from one of our residents, about learning more about what people find helpful in terms of information and like communication about things. We have a question from one of our Grady colleagues. I think you're doing this important work. As you point out, the interesting cases are less important to follow up on the routine cases with surprising challenges in care, making it challenging for clinicians to choose which cases need follow-up. How should we choose which cases to start to chart check?
Yeah, that's a great question. I think, and we've thought about this a lot, especially as we talk about the Calibrate DX and which patients to use or which cases to use. We've actually decided just to do routine. So we're actually like telling people to use like either hyponatremia, like dyspnea or abdominal pain as like pretty common complaints to use those. Like, don't go after the zebras. I feel like those, like the ones that are so complicated. I think Rob L. Curry from UCSD did some great work looking at how often charts were accessed based on kind of the complexity of the patient and then looking at the number of errors and actually cases where the chart wasn't accessed as much because they weren't as worried about it were off like had more errors and cases where patients are super complicated because we were going back and we were so vigilant. So like I would say pick your bread and butter because I think it's sad to think how long we could be wrong with the bread and butter cases.
And then our greedy residents had a question. Thank you again. This is such an important topic for patient care. Another transition point that's high risk is a transition from admission to discharge. Have you considered how to provide feedback in that setting?
Yes, that's such a great point. Yes, we have a discharge clinic and a transitional care clinic for some of our patients. I think what we're trying to work on is we're going to try to pilot something small with one clinic. So we've got a bunch of them. So maybe if we can chart with one clinic and see if how feasible it is for the busy primary care doctors or even the transitional care doctors to provide the feedback. If we can find an easy way to provide this and maybe even using rather than having it be a survey, rather we can use similar to what University of Minnesota did with like a secure messaging. If we can just have a prompt filled out to see how to go, can you send us some information and have it be a really quick either click or a brief typing to get that back. That's definitely a transition point we want to focus on too. These are great questions.
What other questions y'all have? One question I have, just
Mhm.
thinking about culture and change. I loved how you worked really hard up front to get buy-in from folks, and I'm sure that made a big impact. After you had launched, did you still end up experiencing, some degree of reticence to give feedback? And were there any other strategies you and your team used to kind of help folks work through like the discomfort of giving one another feedback and kind of finding helping shift that culture to one where this has become the norm?
Yeah, so I think interestingly, when we first started the project, people weren't sure they wanted to be identified in
Mhm.
terms of the feedback, but we're like, if we're going to be able to provide the case, then you have to be identified. So actually, the first kind of little tidbit of pilot before we started the project, we did this and we did not provide the case. And people were like, well, this is worthless because I want to know what the case is. I want to look at it. We're like, then you're going to be identified. Like, then you're going to have to be like, which way do you want it? And we, went back to the group and kind of talked about it. And at that point, they're like, okay, no, give us the case. And even if that means that I'm going to be calling out a colleague for a diagnostic change, I probably should be comfortable telling them anyway. So when we first had to kind of show them to be like, I'm going to give you a case with absolutely no details. You cannot look them up. But if that's what you want in terms of anonymity, and like we're not like a mean group, I feel like we're pretty, got the just culture. We're pretty psychologically safe. But I think people just felt uneasy at first. There were I think there's a couple people who was like, it was hard to swallow getting the feedback, especially about an error, and would still be like, well, I'm not sure I agree. And that's fine. As long as they accepted the feedback and took it, they'd still continue to do their surveys, they still continued to request feedback, then that's all you can do.
I think that's a great approach. The sort of like sort of backdoor attack of like knowing that we would want to know these things and just sort of like putting it out there and making them sort of come out and say that. is so very smart. And yeah, just a challenge for so many folks in terms of like getting feedback that I think once people start doing it, like we do a lot of peer observation, it can, be really impactful for both parties. Thank you for this wonderful talk. This concept has so many potential applications in other specialties as well. Is broadening this outside of internal medicine something that you would consider in the future?
Yes, so we've expanded it to the ER right now. So the ER is kind of doing this now. And I think we have a quality improvement consortium here with this group. With this project was really like kind of formulated and kind of created. So a lot of the specialists were kind of involved in that and are interested in doing it in their own way of like how can they even attending to attending kind of have some sort of a feedback mechanism so they can provide on their own cases. So I'm happy to be involved in that, but I'm not a GI doctor, so however they want to take the idea and go with it is great. But I think it's applicable across multiple fields.
That's a great point, and certainly ample opportunities between hospital medicine and the ER to collaborate on that.
Yeah,
What other?
especially in admission, we see, I
Yeah,
feel especially with the ER, I feel bad for my ER colleagues, but there's a lot of like hand over to hand over to hand over in terms of before it comes to me,
yeah.
that I admit it. And so what we did is we reviewed cases of admissions and then provided it back to the ER and said, here's our findings, you do with it what you want. So like you can give it to whoever you feel is the correct person that made most of the decisions. That doesn't have to be we don't have to do that, and that's also not a separate department providing this. So if that's and they came to us asking for the feedback, so it wasn't like we were imposing kind of our thoughts on them, so they were happy to receive it.
Dr. Bonsall says, great to see you and great talk slash project.
Thank
What
you.
other questions y'all have? All right. Well, I think we've asked all of our questions. Thank you again to Dr. Astik for this fantastic presentation. Certainly given a lot of us something to think about. And just a quick reminder for everyone, this is our last grand rounds of the season. So have a great summer, and we will see you in September when we get started back up. All right.
Thank
Thanks,
you.
everyone. Bye, y'all.